Can I ask Dr. Yu, please come up to the stage? So we have some time for a few questions. You can line up in front of the mic. Please go ahead.
Thank you both. Very good talks. I enjoyed them. Evan, I wondered if you could let me know where to do AR-V7 splice variant testing. Is it commercially available?
Yeah, it's not commercially available yet. There's discussion that the genomic health technology might be available soon. But there's multiple ways to test it. There are PCR-based assays. There are protein-based assays. I think there are challenges right now, and I think one of the concerns that I have is that it may become available and everyone may start using it when we haven't quite validated it yet. I think you can tell that I have some caution about just how common this is occurring. I suspect it might not be occurring as commonly as what the published literature is showing, and I also wonder whether this is really a driver or not. So I'm going to be cautious in regards to common everyday use for now until I see more data.
I would suspect we would be using it more with failure of one of the agents like enzalutamide before proceeding with the other.
That would probably make the most sense, I think. Yeah.
Also, have you used Sophiego at all together with Abiraterone off clinical trials?
Yes, I have, and there are some people who exclusively do that since, Sophiego doesn't decrease the PSA, and it's certainly an easier thing to keep a patient on. I would say that, here in the Northwest U.S., sometimes we have insurance third-party payer challenges. I found it a little bit easier to just add Sophiego on later to abiraterone. Somebody that's on abiraterone, PSA's rising, maybe they're starting to develop some symptoms, and then I'll add it on at that time.
One other question, how do you know when a patient is failing Provenge because the PSA doesn't change? Are you looking at bone pain and things like that?
There's really no way to know. So what I do is after I give somebody Provenge is I monitor their PSA and their re-imaging scans. Certainly somebody that's symptomatic, I'll start the next line of therapy, but I try to wait for a while before I start the next line of therapy. Oftentimes I'll tell patients that, let's try to give it at least 3 months, if not 6 months, and then we'll restage you, and that'll kind of serve as a new baseline from this point on, assuming that maybe not much has happened in the very beginning or your immune system's just revving up. So I kind of play it by ear. If the PSA is rising slowly, scans are pretty stable, I'll just keep observing them. But if things are moving, then I'll throw on abiraterone and enzalutamide.
Any other questions?
Bladder question, the micropapillary variant of bladder cancer, any experience with immunotherapy in metastatic micropapillary variant?
Well, unfortunately, the clinical trials that have been done have excluded variant histology, which I think is a darn shame, because as we start heading into drugs that treat specific biology, you might argue some of these variants may actually have the biology that we're looking for. If you look at micropapillary tumors in general, we published some data in European Urology, again looking at the molecular classification using gene expression profiling. The micropapillary tumors appear grossly luminal, so we see a lot of luminal tumors, but some of them also have that P53-like luminal histology where they may have an immune infiltrate. So while I think the luminal tumors may do worse with immunotherapy, if they do develop that infiltrate, there's probably something different about them compared to the FGF receptor-driven tumors. And I personally would try immunotherapy, but there really isn't any data yet on immunology or immunotherapy with micropapillary. I can tell you my one patient, again, the one in the Times, who's at long-term durable remission, had plasmacytoid tumor of the bladder. And we actually had a path report that we found that suggested greater than 50% urothelial cancer and less than 50% plasmacytoid. Although I personally believe if it's plasmacytoid, it's plasmacytoid, regardless of whether they report conventional components. So only because we had that path report was he allowed to go on the trial. And again, a durable, complete remission after failing multiple prior lines of treatment. So I've been arguing for inclusion of these variants. Could be a separate arm of the trial if they'd like, or just include them in general. We might find that some of these variants actually have the biology that we're looking for.
Any other questions? All right, we have time for a short break before our next talk, but just want to remind people that there's an evaluation form that should be sitting on your desk or on your tables. If you guys can please fill that out sometime today before you leave. It's very important for having more of these conferences. So we'll take a few minute break and then we'll start our GI talk after this. Thank you very much to our speakers.